Gentlemen, I'm sure it was a very interesting symposium and there will be a lot of questions and interactions. I would just like to give the concluding remarks, kind of summing up what has already been said in great details. So the outlook for patients of breast cancer has improved significantly over the past few decades. And the reason why this has happened is because of early detection due to screening mammography. As far as our country is concerned, maybe we are still not there, but it's something that our health planners will have to look to in the future, particularly in the urban areas where the incidence of breast cancer is rising considerably, and with the better therapeutic options that we have just seen. As far as surgery is concerned, I think the take-home message, of course, would be that breast conservation surgery has come to stay. In Western countries, of course, it is the predominant surgical modality of treatment, but in India, I think mastectomy still has an important modality for various reasons. One, because some of our tumors present very late, and sometimes, as has already been highlighted, patients may come from long distances, and it's difficult for them to actually wait for radiation for so long. And oncoplastic breast surgery is now fast emerging as a subspecialty in the West. I think India is also catching up in this field, and we shall soon possibly be having surgeons who are doing exclusively oncoplastic breast surgery. As Dr. Mahapatra has highlighted, chemotherapeutic options have changed from the days of CMF to anthracyclines and now taxanes in the management of early breast cancer. Of course, in metastatic breast cancer, we have many more options. Taxane resistance is an important factor. Epithelials are also coming up. But as far as the adjuvant therapy for breast cancer is concerned, early breast cancer, we are now in the stage where anthracyclines and taxanes are being used. He has highlighted in great details the various options that are available. In premenopausal hormone receptor positive patients, there was a time when only oophorectomy possibly was an option, but today we have Zoladex, which actually does a chemical castration in these patients, and tamoxifen still has a role to play. The role of aromatase inhibitors in the premenopausal women is still under investigation. But in postmenopausal hormone receptor positive patients, there was a time when adrenalectomy and hypophysectomy was used to achieve the kind of aims that we are achieving with just single tablets a day. Tamoxifen, as Dr. Mahapatra has highlighted, has actually served breast cancer patients immensely and still continues to do so. But the third generation aromatase inhibitors like Arimidex, Exemestane and Letrozole are now gradually replacing it in various ways, in various combinations, as has already been highlighted. Anti-estrogens like fulvestrant or Faslodex have still not found a place in the adjuvant setting in early breast cancer, but they do have an important role to play in metastatic breast cancer, hormone receptor positive, which have failed aromatase inhibitors. However, maybe in the future they could also be important in early breast cancer. Targeted therapies have also been alluded to, and most importantly, of course, we have patients who are HER2/neu positive, and in these cases, trastuzumab has, sorry for the wrong spelling, trastuzumab has proved to be of immense role in actually increasing the disease-free intervals and prolonging overall survival, both in the adjuvant as well as in the metastatic setting. Lapatinib, as of today, is approved only in the metastatic setting, but there are, as Dr. Mahapatra has said, a lot of trials underway where it could possibly be used upfront in the adjuvant setting as well. I think it is a complex issue. Multimodality of treatment is extremely important, and I think the panel would like to welcome any questions that would be raised.